Okay, so regarding the clinical features, the most important presentation of such patients is the acute urinary colic. That's a severe episodic colicky pain, and which actually maybe patient can actually present with the right or the left side, or will point out that I have a pain in my right flank or left flank. It's radiating to the back, and it's a episode for a few, lasting for a few minutes, and then it goes by on. So just like the biliary colic, it's a urinary colic. I swear, pain and intensity and excruciating and lasting for minutes and then goes back on its own. This is called as acute urinary pain, and maybe it's also accompanied with the vomiting. Pain is accompanied with the vomiting. Sometimes hematuria, but this hematuria is not maybe frank, okay, but sometimes there can be occult hematuria, and when you try to send the urine for routine examination, there can be RBCs as well. So not possible that there may be frank hematuria, but there can be hematuria which is occult. Okay, and the renal pain, again, the same pain, maybe possibly in the down in the tract. Okay, or maybe anywhere in the part of the kidneys, maybe upper middle or the lower lobe, radiating to the back. Now, another important thing, it's possible that the patient may have only the obstructive symptoms, or maybe he should have infective symptoms as well. So the obstructive symptoms would be, obviously, the patient will tell you that I have urinary incontinence and I have urgency and a frequency, and or acute episode of the urinary colic. But sometimes they're accompanied by fever and vomiting and tachycardia, and the patient is nauseatic, and obviously all the signs of the inflammation with tachypnea and tachycardia and fever. So that would indicate the patient has obstructive and infective symptoms as well. Again, nausea and vomiting is one of the any pathology related to infection that can cause these symptoms. Remember, acute urinary colic pain, renal pain, and when you try to examine such patients, there is and you try to punch them back on the renal. If the patient has pyelonephritis along with the stone. So what you do, you try to punch the patient on the back, so the pain is increasing intensity. That is called renal punch sign. So that's actually the renal punch sign is positive. Painful urination, as maybe dysuria, because it's accompanied by urinary tract infections, and maybe possible the patient will complain to you about the ureteric colic and urinary incontinence and urgency as well. And obviously, when you are on the basis of the clinical features, you have to send some labs, and the basic labs are, you have to go for a blood CP, you have to go for the quantitative CRP, you should go for the urine RE, but the most important in the diagnostic thing is a CT scan, which is a CT kidney ureter bladder, CT KUB, which is non-contrast CT KUB, and sometimes a stone may be possible. You can pick it up in ultrasonography, but usually smaller stones, they're not picked up on ultrasonography, and obviously you have to go for the CT KUB. Sometimes if the stone is radio-opaque, then you can pick up the stone on the plain radiographs, and you have seen the patient and the size of the stone is less than 5 millimeter, and you have sent the patient home on a medical therapy, and you are just planning to call your patient for the follow-up. So you can use a plain radiograph for the radio-opaque stone for a follow-ups. Okay, so the gold standard investigation for the renal stones would be CT KUB non-contrast, and then you can obviously sometimes people also go for intravenous urogram or pyelogram, contrast enhanced, but remember, non-contrast CT KUB is a very good gold standard investigation when you're trying to investigate the nephro-urolithiasis.